and a consultant who is a reader. Dr. Jokotade Adeleye is a reader and a consultant endocrinologist in the endocrinology unit of the Department of Medicine, the College of Medicine, University of Ibadan, and the University College Hospital, Ibadan, Nigeria. She attended the prestigious and the premier University of Ibadan, the College of Medicine, between 1983 and 1989, where she graduated and she obtained the MBBS degree in November 1989. She is a fellow of the West African College of Physicians, and this she has attained since April 1999. I will not want to go further because of our time. So please welcome with me Dr. Jokotade Adeleye as she makes a presentation in 20 minutes. And then after our presentation, I will also introduce Dr. Mark Mojola, who is going to make another presentation. The presentation today, it's about neuropathic pain. And so we have two presenters making this presentation. Thank you, Dr. Adeleye.
Thank you very much, sir. Thank you, distinguished ladies and gentlemen in the audience and senior colleagues and colleagues. I will be speaking on pain in diabetes mellitus. And this is the outline I intend to follow for this lecture, as shown in the slides before you. Diabetes mellitus is defined as a group of metabolic disorders characterized by persistent hyperglycemia due to defects in insulin secretion, insulin action, or both, resulting in disturbances of carbohydrate, fat, and protein metabolism. The current classification of diabetes is an etiological classification. The vast majority of persons with diabetes have type 2 diabetes, which accounts for about 80 to 90% of persons with diabetes, while type 1 diabetes accounts for about 5 to 10%. There are various other types of diabetes, but type 1 and type 2 account for the vast majority. I want you to look at the first column of this slide before you, which shows the burden of diabetes in the world. As at 2024, the International Diabetes Federation estimated that about 588 million persons were living with diabetes. And by 2050, it's estimated that about 853 persons will be living with diabetes. In sub-Saharan Africa, about 25 million people are estimated to be living with diabetes and expected to more than double by 2050, by about 60 million. And worrisomely, the greatest increase in the burden of diabetes is projected to be in sub-Saharan Africa, with a 142% increase expected. Of concern is that for every one person diagnosed with diabetes, there is at least one other person undiagnosed with diabetes. And the slide before you, you can clearly see that also in sub-Saharan Africa, the highest burden of undiagnosed diabetes also lies with us. The burden of diabetes mellitus in Nigeria is estimated by the International Diabetes Federation at about 3 million adults. However, this is thought to be a significant underestimate. A meta-analysis and systematic review by Professor Olamoyegun et al. In 2024 gave a pooled estimate of diabetes of about 7%. And so the actual number of persons living with diabetes is thought to be closer to 11 million. And for every adult diagnosed with diabetes, it is believed that at least one other person also has diabetes, but yet to be diagnosed. Now, going to our topic for today, pain and diabetes. Pain in persons with diabetes is a major symptom of diabetic neuropathy or diabetic nerve disease. Current estimates suggest that up to about 50% of persons with diabetes will develop some form of neuropathy. and that figure is thought to be slightly higher even in developing countries. The clinical manifestations of diabetic neuropathy vary immensely and could be associated with pain or could be painless, or sometimes both painful and painless. Diabetic peripheral neuropathy or diabetic nerve disease with diabetes, peripheral arterial disease, peripheral arterial disease is intermittent claudication. That's pain or a cramping pain in the calf, the thighs, the buttocks on exertion relieved by rest, but is actually absent in the majority of persons with diabetes who have peripheral arterial disease. It can transition into rest pain due to ischemia, which is notoriously worse at night. But because the vast majority of persons with diabetes and peripheral arterial disease don't even have classic pain, the vast majority of persons with diabetes who will come with pain will have pain due to neuropathy, diabetic neuropathy. The most common painful neuropathy in persons with diabetes is known as distal symmetrical polyneuropathy, or DSPN, as I will be referring to it in much of this presentation. The prevalence of DSPN varies from about 14.5 to 57.2 in various studies, utilizing various methodologies, with a pooled prevalence of about 46.7%. So it is something that's quite common in persons with diabetes. DSPN is the most common form of painful diabetic peripheral neuropathy. And basically, we're talking about a symmetric polyneuropathy involving multiple nerves and affects the longest nerve fibers, which is why the symptoms start in the feet, where the longest nerve fibers are affected first. And characteristically, its symptoms are gradual or insidious in onset. In DSPN, the pain typically starts in the toes, with progression proximally to involve the feet and the legs in what is called a stocking distribution. It's described in various ways: burning, biting, sharp, shooting, electric shock, various ways. And patients may also complain of allodynia, whereby even trivial things like the bedsheet touching their feet elicits significant pain. As the severity increases over a long period of time, it may later involve the upper limb, causing pain in the fingers and progressing proximally. The pain can be intense, can be disabling, and it is often more severe at night, waking them up from sleep or preventing good sleep. On examination, there may be motor manifestations such as wasting of the small feet, weakness of the limbs, and interestingly, a patient may be complaining of intense pain, but may also have sensory loss, that is unaware of sensation or pressure, and this further increases the risk for foot ulceration. So a patient may be complaining of intense pain in the feet and yet have lost the ability to perceive pressure and pain, which we call the painful, painless foot. The physical discomfort from pain also has psychological and economic consequences, which can imposing substantial costs, both direct and indirect, having to access care, cost of care, missed days at work or missed time from their workplace or place of vocation, and the intensity of the toll of the pain can result in decreased quality of life. Some of the consequences of distal sensory polyneuropathy, which is the commonest cause of pain in diabetes and of peripheral neuropathy, include sleep deprivation and exhaustion. The pain is worse at night. It's been found from various studies to correlate with an increased risk of or presence of depression, anxiety, and other mood disorders. It could, when at its worst, impair functionality, daily activities, and there's the cost of care, the cost of medication, having to seek help. And we know that the cost of care and medications and treatment is quite high in our environment. This slide before you shows risk factors for diabetic neuropathy. We know that glycemic control, as determined by the HbA1c, average blood glucose over the last 2 to 3 months, is a major risk factor for diabetic neuropathy in the presence of persistent hyperglycemia. The presence of advanced age, or older you get, the greater the risk. People who are sedentary, not active, have a greater risk. The presence of a cluster of cardiometabolic factors, hypertension, dyslipidemia, which also are present in the metabolic syndrome, also increases the risk. But for painful neuropathy, all these factors apply, plus it is commoner in females compared to males, more likely in those who are overweight or obese. Of course, to even have painful neuropathy, you must first have neuropathy, so it is a risk factor. The presence of renal dysfunction and genetic predisposition is thought to play a part in the development of neuropathy. Persons with similar blood glucoses, one person develops neuropathy and painful neuropathy, one person doesn't. We know that the longer-term glycemic control would increase the risk for developing neuropathy and progression. As I said earlier, the longer one has had diabetes, particularly if glycemic control is poor, increases the risk of development and progression, and the presence of hypertension, lipid abnormalities, or a cluster of cardiometabolic factors known as the metabolic syndrome further increase the risk of developing neuropathy, painful neuropathy, and progression. Just to briefly mention that there are other types of neuropathies which can be associated with pain in persons with diabetes. The radiculoplexus neuropathy refers to a disabling complication of diabetes in which there is damage to the plexuses of the nerve roots. Pain is a prominent symptom. And the most common type of this type of neuropathy affects the lower extremities by virtue of a lumbosacral radiculoplexus neuropathy. Less commonly, it can affect the thoracic and the cervical regions, less commonly. So in the lumbosacral radiculoplexus neuropathy, formerly known as diabetic amyotrophy, there is typically unilateral proximal limb pain, which can be described as a lancinating pain in the hip, the thigh, or the buttocks, preceding motor weakness. So the pain, then the progressive weakness and atrophy of the proximal muscles with reduced deep tendon reflexes. It may be accompanied by other forms of abnormal sensation. They may be insensate, and they even be autonomic manifestations in some of these patients. When it does involve the thoracic plexus, it would cause burning pain and paresthesia in a band-like distribution, typically around the chest or the abdomen. There is a rare form of neuropathy known as treatment-induced neuropathy, and this is usually an acute or subacute onset of pain, described as burning, shooting pain, rapid onset, as opposed to the insidious onset of DSPN, with severe neuropathic pain, sensory disturbances in a stocking and glove, where it affects the left feet, stocking, glove, the hands. And it typically occurs in the setting of rapid correction of glycemia within 6 to 8 weeks. So when a patient suddenly develops acute painful neuropathy in the feet or the hands, coinciding with a period of rapid improvement in glycemic control, treatment-induced neuropathy should be considered, and this basically can resolve or will resolve with time. Diabetic neuropathy can also involve discrete nerves, causing pain in the distribution of the nerve supply. For example, involving the cranial or oculomotor nerve, causing unilateral pain above and below the eye, or the radial nerve, the ulnar nerve, the median nerve, and giving pain in the distribution of those nerves. But as I said earlier, by far the most common cause of pain in persons with diabetes is distal symmetric polyneuropathy. Chronic hyperglycemia plays a very central initiating factor of diabetic neuropathy. I did mention glycemic control being a major risk factor. And chronic hyperglycemia leads to an interplay of metabolic, vascular, and neurodegenerative processes by various pathways. The polyol pathway describes the conversion of excess glucose into sorbitol, which results in osmotic stress, oxidative damage, and nerve damage, impairing nerve conduction. Another pathway known as the hexosamine pathway, where excessive glucose has been found to galvanize this pathway, leading to vascular dysfunction, the vasa nervorum, the nerves, inflammation, and oxidative stress, leading to neuropathy. The formation of advanced glycosylation end products. Every protein is glycated, and when there's hyperglycemia, there is an increased formation of advanced glycosylation end products, which leads to pro-inflammatory cytokines expressed, oxidative stress, inflammation, and vascular dysfunction, leading to neuropathy. And protein kinase C activation is another pathway which is disrupted in the presence of chronic hyperglycemia. And this results in abnormal neuronal metabolism, abnormalities of pain, hypersensitivity to sensation, or nociceptive stimuli, and oxidative damage. As I had mentioned earlier, the presence of dyslipidemia, insulin resistance, or altered insulin signaling in the presence of insulin deficiency contribute to the pathogenesis of diabetic neuropathy. Painful, DSPN, or whatever type, independent of hyperglycemia. And these have all been shown to cause pathological changes in the neurons, increased neuronal programmed cell death, and vascular changes, which cause neuropathy or nerve dysfunction. In addition, hyperglycemia has been reported to cause reduced levels of neurotrophic factors. And this neurotrophic factor deficiency leads to neuronal atrophy, impaired nerve and axonal transport, and decreased ability for the nerves to regenerate. So, genetic predisposition also plays a part. I had mentioned earlier that you might have two patients with similar duration of diabetes, similar duration of hyperglycemia, and one develops neuropathy, the other does not. And genes are thought to be associated in responses to inflammation, oxidative stress, and neuronal dysfunction, leading to susceptibility to neuropathy. And this slide basically summarizes all I have said, the various mechanisms: hyperglycemia, dyslipidemia, vascular risk factors, insulin deficiency resulting in nerve damage, neuronal cell death, vascular damage manifesting as neuropathy in its various forms and types. So, when we have patients with diabetes who have pain, it is important to take a good history and a thorough physical examination. It is important to do a good neurological and vascular examination of the limbs when involved, often start with the lower limbs, and consider, are there any red flags that might suggest other causes of pain other than neuropathy? There are various scoring systems for assessing for neuropathic pain. I've shown a few in the slide before you. And it is important to do a sensory or motor examination. I did mention that the presence of pain due to diabetes neuropathy does not mean that that patient has good ability to perceive sensation. The foot could be insensate. And this slide shows various modalities of sensation that we do use to test, to assess whether the foot is insensate or not. There are various ways of also diagnosing neuropathy using scoring systems, which consist of a composite score of various abnormalities, as shown in this slide also. Laboratory investigations also play a part. First and foremost, measuring the long-term glycemic control, known as the HbA1c. Well, for patients who can do some home glucose monitoring trends and patterns in relation to meals, medication, lifestyle is important. Assessing lipid profile and measures of renal function, EU creatinine, the presence of albuminuria, because we know CKD increases the risk for neuropathy and painful neuropathy. Electrophysiologic studies, such as nerve conduction, are the most objective, non-invasive measures of nerve function. But in most clinical scenarios, it is not required. Advances in diagnosis include confocal corneal microscopy. It's a non-invasive imaging technique that visualizes the corneal nerve fibers. It's said to lead to very early diagnosis of neuropathy before symptoms appear. But this is also something that is not necessary in most clinical scenarios. This slide before you just summarizes the management modality. I will be talking about the first column about means of prevention and early diagnosis, while my colleague, Dr. Mokonjola, will very soon take on the other aspects as regards treatment modalities, pharmacologic and emerging therapies. This summarizes it. In the management of painful diabetic neuropathy, or in the prevention or early diagnosis, prevention remains the best strategy where possible. We're talking about trying to achieve intensive glycemic control to reduce the risk of even developing neuropathy and consequently painful neuropathy. So proactive primary prevention and, where necessary, early intervention is crucial to mitigate the disturbing consequences I mentioned earlier on. It is a multidisciplinary care approach that would involve various types of medical personnel, not limited to what I have in the slide before one, but together everyone achieves more. There have been certain landmark trials on glycemic control. And what are the lessons? And I will briefly touch on that in the next few minutes. The diabetes control and complication trial, where in patients with type 1 diabetes, they aim to achieve intensive glycemic control, showed a 60% risk reduction of developing neuropathy. The United Kingdom prospective diabetes study in patients with type 2 diabetes showed a very modest reduction in the risk of developing neuropathy. And subsequent landmark trials, known as the ACCORD and the VADT trial, showed that intensive glycemic control could slow progression in type 2 DM, but did not significantly prevent the onset. So lessons from the landmark trials show that hyperglycemia is indeed crucial in the pathogenesis, and achieving intensive glycemic control as early as possible and maintaining it is one of the multiple factors contributing to neuropathy. But we must consider other facts, and a multifactorial risk intervention is best. It is important to achieve glycemic control because even the presence of hyperglycemia worsens the pain in patients with distal sensory peripheral neuropathy. And it is a general consensus that achieving good glycemic control is a major first step in management, but earlier is better before too much damage has been done. We choose to balance the benefits of intensive glycemic control, where the target is an HbA1c less than 7 in most adults, against the risk. But one size does not fit all, and we must individualize glycemic targets. Lifestyle is still a cornerstone. A healthy diet, lots of vegetables, including fruit, complex carbs, whole grains, less of processed foods in moderation. Regular physical activity, if the patient is fit enough to tolerate that, and smoking cessation. And patient education is key. We must be able to equip patients with diabetes to be able to help themselves to adhere to the various choices and lifestyle measures required. Irrespective of whether the patient has painful or painless neuropathy, all patients with diabetic peripheral neuropathy, whether painful, painless, painful, painless, require education on preventative food care. And this has been shown to be successful in reducing ulceration and amputation rates in persons who have lost protective sensation. So, a multifactorial risk approach is best for neuropathy, painful neuropathy, or pain in diabetes. There is a solid rationale for intensive management of glycemia, as I've said earlier, but look beyond just glycemic control. The control and treatment of dyslipidemia, hypertension, other components of the metabolic syndrome, which I earlier mentioned, have been implicated in the pathogenesis of diabetic neuropathy. So, not the glucocentric, a multifactorial risk approach is best, treating these risk factors to target through lifestyle measures and pharmacologic treatment. And in the management of painful diabetic neuropathy, DSPN, there is a place for pharmacologic therapy and other emerging therapies, which my colleague, Dr. Makonjola, will take. These are my references, and I thank you for your attention.
Thank you very much, ma'am. Thank you for such wonderful and very, very easy to understand presentation. I want to say I am not surprised. In my few years of being alive, I think I've known Dr. Adeleye more than half of my being around. So I understand why this is just an easy peasy for you. Thank you very much. Yes, Dr. Makonjola has been mentioned several times, and it's because he's going to make the presentation from the neurologist perspective. The presentation, both presenters are speaking on pain in diabetes. Dr. Adeleye is an endocrinologist, and she has invited Dr. Makonjola to join in making this joint presentation. Dr. Makonjola is a neurologist. I would crave indulgence of the members to quickly read Dr. Makonjola's biodata. Yes, Dr. Makonjola biography. So, sorry. Dr. Akintomiwa Makonjola is a consultant neurologist and an associate lecturer in medicine at the University College Hospital, University of Ibadan, and the College of Medicine, University of Ibadan, Nigeria. He obtained his MBBS degree from the University of Ibadan and a Master of Science in Clinical Investigation from Northwestern University, Chicago. He was awarded the Fellowship of the West African College of Physicians with specialization in neurology upon completion of postgraduate medical residency training in internal medicine at the University College Hospital, Ibadan. His clinical interests are in general neurology, including peripheral nerve and neuromuscular disorders, stroke, and neurocritical care, while his research interests include stroke, HIV neurology, dementia, and neurodegenerative disorders such as ALS. Please welcome with me Dr. Akintomiwa Makonjola, MBBS, MS, FWACP. Dr. Makonjola, you have the floor, sir.
Thank you very much for your kind introduction. Please, if you just give me a few minutes could you please make me a co-host so I can share my slides, please?
Yeah, sir. You're a co-host already.
Thank you very much. All right. Can you all see my slides, please? Okay.
Yes, we can.
Okay. So I'd like to, first of all, thank the society for inviting Dr. Adeleye to speak and to thank Dr. Adeleye for inviting me to join her. As I'm sure you all have, I have benefited immensely from her presentation. And she has made my work easy. In football parlance, I would say she has given me a through pass. And so all that's left for me is just talk briefly over the next maybe 10 or 15 minutes about pharmacological management of painful diabetic neuropathy. So this is what I'll use to direct my presentation. I'll talk briefly about the mechanisms of pain in diabetic neuropathy. Dr. Adeleye has already sort of given the background of the pathophysiologic mechanisms that underlie neuropathy in general. And so I'll just talk briefly about some of the things that can cause pain. Then I'll speak briefly about some of the principles of pharmacological therapy in painful DM neuropathy. And then I will talk about what medications are recommended by the American Academy of Neurology and the American Diabetes Association. And then I'll talk briefly about other treatments, some of which are emerging. So Dr. Adeleye has spoken about this. These are the patterns of nerve injury in diabetes, the glove and stocking type, the mononeuropathies, the radiculoplexus neuropathies, which can either be thoracic or lumbosacral, and then the autonomic neuropathies as well. And then, so this just again summarizes the clinical features you see with each type of nerve fiber that is affected. Again, Dr. Adeleye has spoken extensively about that. And so what are the things that drive pain in diabetic neuropathy? So there are peripheral and central mechanisms. So as we know in diabetes, there is increased, there's abnormal glucose metabolism, and that leads to increased glycemic flux, even at the peripheral nerve level. And that sometimes causes bioenergetic failure, accumulation of abnormal metabolites, some of which can instigate oxidative stress, inflammation. There is some element of peripheral vascular dysfunction that causes ischemia of the epineural tissue. There's all that eventually leads to small nerve fiber damage. And as we know, that pain and autonomic function are mediated by small unmyelinated nerve fibers. That leads to axonal atrophy, degeneration, and some attempt at regeneration. And that nerve fiber damage then alters the expression and distribution of various ion channels and neuropeptides, all of which then cause the nerve to be hypersensitive, which is what leads to the hyperalgesia, which is exaggerated response to pain, or allodynia, which is experiencing pain even when the stimulus is a non-noxious stimulus. So the nerve ends are hyperexcitable, they are hypersensitive. There's also some abnormal sprouting of sympathetic fibers, and there's also loss of inhibitory control from the spinal cord. On the other end of the spectrum, there are changes in the central nervous system as well. So there is increased thalamic activation. As we know, the thalamus is the center of sensory processing as well as pain. At least it plays an important role in pain processing as well centrally. So there's increased central sensitization. There is an alteration in the balance between the excitatory and inhibitory signals in descending pathways that is skewed in favor of excitation. Again, so there's increased central activation and increased central sensitization. And there's also accompanying behavioral and emotional dysfunction, as Dr. Adeleye mentioned. There's often association with depression. There's often association with sleep disturbance, and so on and so forth. And as well, there are some central autonomic changes as well. So these are some of the mechanisms that underlie pain in painful diabetic neuropathy. And this image just summarizes some of the peripheral mechanisms. So there's an alteration in noxious transducer activity. As Dr. Adeleye mentioned, there are several predisposing factors, including genetics, metabolic derangements that is prevalent in diabetes, inflammation I mentioned, and vascular dysfunction. So there's increased susceptibility to hyperexcitability, ectopic firing of the nerves, and then increased membrane depolarization. And that leads to increased presynaptic release of excitatory neurotransmitters, and then potentiation of postsynaptic signaling. And then some of the neurotransmitters that are involved are noradrenaline, glutamate substance P, and then the serotonin and noradrenaline that are shown here. They are like the neurotransmitters that are present in descending control fibers. So, and it's important to take note of this because when we talk about some of the medications, these are important in the mechanisms of action. So these nerve endings are descending inhibitory controls, and they have serotonin and noradrenaline as the neurotransmitters. So generally speaking, when we think about the management of painful peripheral neuropathy specifically, and peripheral neuropathy in diabetes, generally speaking, it involves treating the underlying cause, which, as Dr. Adeleye has eloquently and elegantly said, involves, of course, appropriate diabetes therapy, aiming at as near normal glycemia as is tolerable. Excuse me. And then lifestyle modification, as well as multifactorial cardiovascular risk intervention. Then, of course, I'll be speaking mostly about symptomatic treatment of neuropathic pain. That's the second cornerstone. And the third one, which is, not yet fully within grasp, is to sort of develop treatments that will target specific pathways in the underlying pathogenetic mechanisms that underlie peripheral neuropathy. So while there have been some studies that show that some nutraceuticals, which are like basically, you can call them like they're not quite drugs, but they are better than supplements. So they're somewhere in between medications and ordinary dietary supplements. So there's some evidence to show that in like basic preliminary studies, some of these chemicals, some of these molecules are able to interfere, at least experimentally, with certain processes. For instance, oxidative stress or inflammation, or supply of deficient neurotropic vitamins. So, however, a lot of those positive results that have been demonstrated in like preclinical studies have not yet really translated into positive results in randomized clinical trials, and therefore, very, very not all countries essentially are recommending these medications for treatment of peripheral neuropathy in diabetes. So essentially, like I said, I'll be talking mostly about the symptomatic treatment of neuropathic pain. And that then brings me to principles. And so please pardon the fact that this slide is busy, but it just summarizes some of the things that one needs to think about when initiating or contemplating initiation of pharmacological therapy or pharmacologic therapy for management of pain in patients with diabetic neuropathy. So first is to kind of establish that the treatment will not likely abolish the pain, and it does not treat the underlying cause, but the hope is that it offers significant symptomatic relief, and it is often useful to sort of have measurable targets. Like, for instance, using some of those pain scores and other scores that Dr. Adeleye mentioned, you can establish what the patient's baseline score is. So there's a vision analog scale that you can use, or the numerical rating scale. Those are just some examples. Once you establish the patient's baseline, then you can then try to set sort of reasonable targets, therapeutic targets. That, okay, if we achieve 50% reduction in this pain level, that will be considered some degree of at least significant success. So it's always important to sort of establish that. And it's also important to sort of mention that it's important to treat neuropathic pain early, as soon as the patient complains, especially when it negatively impacts patient's quality of life. And another thing that is important to consider when deciding if to treat and what to treat with is to evaluate the patient for comorbidities that may either influence the choice of certain medications or restrict the use of certain medications. So one example is that if a patient, for instance, has comorbid mood symptoms, say depression, depressive illness, depressive symptoms, and so on and so forth, it may be useful to use a medication that has efficacy in both pain reduction and is also useful in treatment of mood disorders so that you limit the patient's pill burden. Or if a patient has like diabetes mellitus and they have prominent cardiovascular disease, then it may limit the choice of something like amitriptyline, for instance, because it can have significant cardiac side effects in terms of cardiac arrhythmias and so on and so forth. Same thing goes for if the patient has comorbid glaucoma, it may limit the use of amitriptyline. So it's important to sort of assess the patients for comorbidities that may influence the choice of medication. Again, it's important to assess the patients for comorbidities that will contribute to poor quality of life, because sometimes treating the pain alone, because pain itself contributes to poor quality of life, treating the pain alone may not improve the patient's quality of life because they have other things that are affecting their quality of life. And if left untreated, the patient kind of just still feels like their quality of life is not improving despite reasonable attempts to treat the painful peripheral neuropathy. So this will include things like sleep related issues, problems with mobility. I've talked before about mood disorders, depression, and so forth. So those are things to think about. And also, of course, that speaks to the fourth point. Pharmacotherapy is selected on the basis of efficacy and the general risk profile of the specific agents under consideration or known or potential comorbidities. And then it's important to try to limit as much as possible the side effects to the medications that the patient may experience. So that may involve using the lowest tolerable dose. In some cases, you may need to avoid medications with known renal or cardiovascular side effects, because we know that patients with diabetes on the long term, especially if poorly controlled, they're at higher risk of developing some of these complications. And then the dose should be titrated, starting from the lowest effective dose to limit rapid onset of side effects. So you start low and go slow. And if necessary, if maybe one agent provides partial or inadequate pain relief, then combination therapy is encouraged. Also, combination therapy is encouraged when the ability to increase a single medication's dose to the therapeutic levels is sort of impaired by intolerable side effects. Then it might be useful to maintain the first medication at a reasonable dose, reasonably effective with minimal side effects, and then add a second medication on top of that. So these are some of the principles that one should think about. And therefore, that takes me to the next slide. What medications are recommended? So this list is basically based on recommendations by the American Diabetic Association and the American Academy of Neurology. And the fifth one, nutraceuticals, like I said, American authorities have not yet approved them for use for treatment of diabetic neuropathy. But in European countries like Germany, Spain, Turkey, some of these medications are approved and are included in their own diabetic neuropathy treatment guidelines. So I'll mostly be speaking about the highlighted first three. Again, these recommendations are essentially derived from the ADA's position paper published in 2017, and the AAN's practice guideline updates, practice guideline recommendations, published in 2022. And these are the levels of recommendation by both organizations. So the ADA considers pregabalin and duloxetine. If I may just take you back 2 slides. So pregabalin and gabapentin, they are alpha-2 delta ligands. So they bind to the alpha-2 ligand. The alpha-2 ligand is actually a subunit of the voltage-gated calcium channel. If you remember, when I spoke about the mechanisms of pain, I said there was altered expression and activation of calcium as well as sodium channels. So what happens is that there's excessive expression of those calcium channels, and that leads to excessive neurotransmitter release at pain synapses. And so pregabalin and gabapentin work by binding to the alpha-2 delta ligand, which is a subunit of the voltage-gated calcium channel, reducing the release of noxious neurotransmitters at the pain synapses. The serotonin norepinephrine reuptake inhibitors, SNRIs, the examples are duloxetine, venlafaxine, and desvenlafaxine. And they prevent the reuptake of serotonin and norepinephrine. If you remember again, I mentioned that serotonin and norepinephrine are the neurotransmitters that are present at that are released at descending inhibitory terminals. Therefore, when these drugs bind, they prevent reuptake because those drugs are metabolized once they are taken back into the presynaptic membrane, presynaptic neuron. So these drugs prevent the reuptake of those neurotransmitters, i.e. serotonin and norepinephrine, causing them to accumulate at the terminal and therefore sort of perpetuating their inhibitory function. And by inhibitory function, what that means is that they sort of reduce the hyperexcitability and spontaneous firing of the nociceptive nerve endings. Then tricyclic antidepressants, they function in a similar mechanism. They are also like they prevent reuptake of several monoamines, but their sort of drawback is that they're not selective like the SNRIs. So they prevent the reuptake of several monoamines, and therefore they have a more significant side effect profile. So coming back to this slide, the ADA considers recommends with level A respect to the American Academy of Neurology, all the medications essentially have a level B recommendation, while topical capsaicin has a level C recommendation. So a rough way to kind of think about these recommendations is that you can think of level A as must do, level B as should do, and then level C as may do. But the important thing about these two recommendations is that regarding opioids, they both recommend against the use of opioids. Although it's important to state that sometimes one is pushed to the wall, and when there is no other alternative, one may, especially in acute settings, acute painful distress, one may be forced to use opioids, but they are definitely not first or second line, if one may say so. And so this image is from the AAN's practice advisory, the AAN recommendations, and it just shows a comparison of the pain-reducing effects of the different classes of medications compared to placebo. So we can see that tricyclics have the highest pain reducing effect. However, the problem with this is that the uncertainty intervals of this estimate are so wide that it makes the effect size questionable. So that's why most those two bodies, they don't kind of, even though it appears to have the highest pain reducing effect, because of the wide uncertainty interval, it causes those organizations to kind of lower the level of recommendation. That just shows that the level of evidence is not very robust. So it lowers the level of recommendation from an A, for instance, to a B in most instances. And the other medications classes that seem to have narrower uncertainty intervals, they have more modest effect sizes compared to placebo with respect to pain reduction. And so this table basically just shows the specific effect sizes. As you can see, 0.95 for tricyclic antidepressants. But again, the uncertainty intervals are very wide and even they cross zero. So it's again explaining why it is ranked slightly lower than the SNRIs and gabapentinoids. And speaking about dosing, the one thing is that many of the studies that have looked at these medications, they use the dosages used in those studies were very high. So the table on the left of the screen is again gotten from the AAN's practice advisory. You can see that for something like amitriptyline, the recommendation based on studies, based on trial evidence, is to go as high as 75 to 150 milligrams per day. And that's a very high dose. That's a dose that usually is often used by our psychiatry colleagues when they are managing patients with depressive illness. So these are really high doses, and with increase in doses comes an increase in likelihood of side effects. Again, look at pregabalin. Most of us are probably only used to 75 milligrams daily, or 150 milligrams daily, or 75 milligrams twice a day. But what the trial evidence shows to be some of those effective doses. However, the table on the right kind of shows, like I mentioned when I was talking about the principles, it's useful to start low and slowly titrate upwards. That way, one can sort of allow the patient to get used to lower doses of the medications and then gradually up titrate as long as there are no intolerable side effects. So a useful guide is to start pregabalin at 25 to 75 milligrams per day, gabapentin at 100 to 300 milligrams 1 to 3 times daily, and so on and so forth. I typically tend to start amitriptyline at either 10 or 12.5 milligrams nocte. Unfortunately, in this part of the world, 10 milligram tablets are not very commonly available. We often tend to find 25 milligrams more often. So we just ask patients to halve the tablets, which brings it to 12.5. And these are some of the side effects. And if one were to consider the potential major adverse effects, one may not even prescribe any of these medications. However, in my personal experience, we write many of these drugs, having considered other comorbidities, right? And, the most common things are somnolence, dizziness, fatigue, and so on and so forth. So that's why we often, for instance, counsel patients use many of these medications at night or start them at night. So that then if any of those side effects come in, the patient can sleep it off and feel better the next morning. I made some comments about amitriptyline. It's a commonly prescribed medication, but please let's be careful in elderly individuals because of the risk of confusion and delirium. In men with bladder outlet obstruction, like prostate enlargement, in elderly men, especially because of the risk of urinary retention. And then also in patients with cardiovascular comorbidity because of the problems with arrhythmias, conduction abnormalities, risk of myocardial infarction, and then exacerbation of heart failure. While many of these potential major adverse effects are not common, at least in my personal experience, it is useful to be aware of them and to notify patients of their possibility. They often occur in very minuscule percentages, if at all. I have never seen any patients with any of these things personally. And for how long does one treat? So the American Diabetes Association, in a clinical compendium series published in 2022, recommends that treatment be continued for at least 6 months of symptom relief, after which an attempt at slow tapering may be done. But if symptoms reappear during that tapering, one may need to keep the patient on a lower dose for a few months and then reattempt to reduce gradually as previously. And so this is just a nice sort of flow chart, confirm that diabetic neuropathic pain. You can either choose any of this based on severity, frequency, and comorbidities and so on and so forth. And then if there is no effect or partial effect, either consider choosing. If there is no effect, you should ideally just switch to another first line therapy. If there's partial effect, one may consider combinations of first line therapies. And like I mentioned, avoid opioids. This is another summary, another like flow chart. A patient with painful diabetic peripheral neuropathy, having explored other causes of neuropathy, aim for good and stable glycemic control. There are a bunch of non-pharmacological interventions, cardiovascular risk reduction via health behavior interventions like exercise, reduce sedentary behavior, dietary modification like Dr. Adeleye has mentioned. Here, these are some of the emerging therapies, non-pharmacological interventions like neuromodulation by nerve stimulation or spinal cord stimulation. Then we've talked about some of these medications, and one may need combination therapy of the pharmacological interventions or pharmacological and non-pharmacological interventions or pharmacological interventions and nutraceutical interventions. And indeed, there was a recent study that demonstrated that they studied 3 different combinations of at least 2 pharmacological medications and found that each of those combinations were superior to placebo in terms of pain reduction, but there was no significant difference in the 3 different combinations that were used. It was a randomized crossover trial. So what that suggests is that the medications you use should be guided by considerations like comorbidity, side effect profile, patient risk, and other patient factors, and so on and so forth. And that if you need to combine, no one combination is necessarily superior than another. And Dr. Adeleye already showed this picture. Just again to summarize the first lines, then you may, when you are pushed to the wall, consider opioids, but remember that several guidelines do not recommend that. And then topical agents may also be useful. Especially 8% capsaicin patch has been approved by the FDA, the American Food and Drug Administration. So I'll just say a word about some of this because of time. I mentioned nutraceuticals, which are basically more biochemically active supplements. So they are not quite supplements that are simply supplementing diet, but they are not, you can't classify them as drugs, but they intervene or they are useful in certain biochemical pathways and may aid pharmacological therapy of a disorder. So alpha lipoic acid is a potent antioxidant. And since we mentioned that oxidative stress is sort of implicated in one of the mechanisms for pain and even neuropathy generally, so it is recommended that in patients that have symptomatic peripheral neuropathy, whether painful or painless, symptomatic peripheral neuropathy, they may benefit from alpha lipoic acid at 600 milligrams daily. And like I mentioned, that's part of the German Diabetic Association's diabetic neuropathy guidelines. Then benfotiamine is a pro-molecule of thiamine, which is one of the B vitamins. It gets converted into thiamine, which is like a cofactor for several biochemical reactions that go on in nervous tissue. So that's the mechanism by which it works. Some other authorities have talked about vitamin B12, especially in diabetic patients who are being treated with metformin, because a significant proportion of them, or let me know, a not insignificant proportion of them that's diabetic patients on metformin may have vitamin B12 deficiency. And we know that vitamin B12 deficiency has very, very important roles to play in nervous system function. So if in patients with symptomatic diabetic neuropathy who are found to be B12 deficient, first of all, patients who are on metformin should be screened for BT deficiency. And if such patients then have symptomatic peripheral neuropathy, then they should have BT supplementation. Even if they don't have symptomatic peripheral neuropathy, as far as they are found to be BT deficient, then they should receive BT supplementation as well to sort of mitigate the effects of BT deficiency on the nervous tissue. And some of the more procedural treatments involve nerve stimulation or electromagnetic modulation of nerve tissue by methods such as transcutaneous electrical nerve stimulation, frequency modulated electromagnetic stimulation, transcranial magnetic stimulation, and spinal cord stimulation. So spinal cord stimulation involves high frequency stimulation of the dorsal column of the spinal cord. And what that achieves is it causes hyperpolarization of the neurons there, causing them to be immune to hypersensitization and ectopic activity, thus reducing the pain neurotransmission, essentially. But these are within the realms of pain management specialists, and there are, of course, some other regular things like nerve blocks and so on that can be done by anesthetic colleagues or pain management specialists. So with that, I've come to the end of my presentation, and if there are any questions, Dr. Adeleye and I will take them. Thank you very much.
Thank you, and thank you very much. I can say again that this is a double tag team. Where we used to watch wrestling, they call it double tag team, and it's been a wonderful one. Thank you very much for this presentation, Dr. Makanjuola. I can say again that truly Akitomiwa is a very great name to be born by someone like you. And now the floor is open. Yes, our time, but again, this is a great privilege to have two presenters on the same topic, and both of them have done justice to, but we know that people can still have some clarifications or some additions. So the floor is open. If you want to raise your hand, you can, so that we can ask you to unmute. And if you want to type, we'll be checking the chat room or chat room, so that we can see whether there are questions there. So the floor is open. Okay, there's a question in the chat group chat. It said, "Thank you very much for the presentation. Please, is the treatment the same for painless neuropathy?"
Thank you for the question. Well, if it's painless, there's no need for the pain medications. However, there's a place for considering the neurotrophic factors Dr. Makanjuola discussed. There is also important to address the underlying predisposing factors, glycemia and other vascular risk factors. Finally, to these patients and looking for things like abnormalities of deformities, the need for insoles to reduce plantar pressure. Sometimes when they are marked foot deformities, they may require specialized footwear and even sometimes surgical interventions. So those would be the things that would be of even great import in those who have painless neuropathy. Also mindful, as I stress, that some people have painless. And when it is painless, it puts the foot at an increased risk because pain can be a blessing telling you something is going on. So those would be the things I have. I don't know if Dr. Bakodila has anything else to add. Thank you.
Nothing to add, man. Everything
Okay.
is used.
Okay. I think a lot of appreciation from the chat. Any question? Thank you for the incisive and educative presentation. Any other question from the participants?
Hello, Dr. Lumide.
Please go ahead, sir.
Thanks for being our moderator in this meeting, and I also appreciate our presenters in today's webinar, Dr. Adeleye and Dr. Makanjuola. We appreciate you for the brilliant presentations. Today's topic is on pain in the diabetes. Can we know the roles of physiotherapists? At least we have physiotherapists in the house, like our own Dr. Dada and our immediate past president, Professor Akepelu. So what are the roles of physiotherapists? Dr. Makanjuola mentioned some modulations. Can we here on this forum know the roles of physiotherapists in the management of pain in the diabetes? Thank you.
Professor Akepelu. Okay, I think Professor Akepelu is not on there. I mean, she's not no longer here. I'll start by saying, okay, I looked at Dr. Makanjuola's presentation first. I mean, where we talk about the transcutaneous electrical nerve stimulation, which is the popular terms, and of course, it's one of the tools that's one of the tools that we use for the management of pain, especially of neuropathic origin. I also looked at the issue of exercise, especially just like Dr. Adeleye spoke about. I know that what we say is that there is also always an exercise for every level. And again, the focus also will also be preventive because you want a situation where you can address the predisposing factors which are better managed before the diabetes becomes an issue for the patient to the point of leading to pain or having neuropathy, and it will always be better to have that. Sometimes especially for those who manage in centers like who manage patients in centers like the the mission centers, the issue of foot protective wears, the kind of footwears, the introduction of insoles or prescription of insoles, the safety in terms of avoiding things that can actually lead to sore or wound. And part of the strategy is always to protect the patient and to prevent the patient from having complications that may be difficult to manage to the point of the patient probably requiring amputation. And if there is anything, okay, for example, the pain as a result of even the amputation and the patient is complaining about some form of phantom limb pain, that there comes in the other modalities. But again, it's just like what we have listened to. It's a multidisciplinary. The major major process is to avoid what would lead to further complications or what can even predispose the patient to diabetic neuropathy. So that's, and then exercise plus, especially as part of the management, in order to encourage uptake even of uptake of the glucose and ensure that there is an enough balance in terms of electrolyte balance, so that the patient does not become the body does not become an abigail of something that allows the increase in glucose to fester. So as much as we can talk about diabetic neuropathy, when we're talking about diabetic neuropathy, we are always interested in the preventive measures and then the protective measures. And if there's pain, then TENS and other modalities can also be applied to manage the pain. Thank you. Any other questions so that we can wrap up or round off?
Yeah, good evening.
Please go ahead, sir. Please go ahead.
Yeah,
go ahead, sir.
Good evening. I appreciate the two presenters, Dr. Makajuola and Dr. Adeleye. Dr. Makajuola has spoken about standard medications for treating diabetic neuropathic pain, but they are also what I call it off-label. They are also used for diabetic neuropathy, like you can use ketamine infusion plus or singly with lidocaine infusion. So while ketamine is a NMDA receptors antagonist that work on the NMDA receptor antagonist, lidocaine 2 tend to calm the overactive nerves, and they are typically used intravenously, although they all have side effects. Like when you use ketamine, there can be symptomatic effects. So also lidocaine can also cause general fatigue, but what you use that when you combine them in low dose, they can be used for people to treat neuropathic pain. Thank you very much.
Thank you, Dr. Akinwale. Dr. Akinwale is an anesthetist, and I think that also reflects, and just like Dr. Adeleye, both Dr. Adeleye and Dr. Makajuola said, it's a multidisciplinary approach, and he mentioned some of the things that our colleagues anesthetists will also be adding to it, and that's a good one. Again, any questions? That it's 8:18. I think it will be a very convenient time to start thinking of rounding off. But let's listen if we have anybody wishing to ask. Okay, Professor Akinpelu is back. There was something on physiotherapy management of pain in diabetes. If you want to add something to that, ma'am.
I'm sure you would have answered that. My line just went off. I don't know what exactly the question is, but I know that exercise, aerobic exercises can be very useful, but we also prescribe proper footwear to minimize the risk of alteration of the feet. But it's got to be regular, and the ability of the patient must be considered.
Thank you very much, ma'am. Yes,
you're welcome.
Thank you very much. Just like you said, I spoke about the two, and Dr. Adeleye spoke about the insole. Usually, we usually try to check with asymmetry distribution because it's also a pointer to where the patient leans on, and what typically will lead to a pressure point. And so usually when the patient comes, we apply that to. I'm so glad that this has provided an opportunity for multidisciplinary discourse, which the Society for the Study of Pain stands for. I can say again that it's one of the largest, if not the largest, society with the largest distribution of professionals. And it's a reflection of what pain management and pain education is all about. It's never a one profession or one discipline thing. So we're so happy to have both Dr. Adeleye, an endocrinologist, and Dr. Makanjuola, a neurologist, and making their presentations today. When I said something about knowing Dr. Adeleye for a long time, some people will be wondering. I can say that the 1999 that Dr. Adeleye joined the system was when we were undergraduate in the University of Ibadan. And so I've known her since then. And so it's a privilege to listen to her today and to say that, let me say this way. It looks as if somebody was just explaining diabetes in a new way. And that was exactly what she did, even with the little time that she had. Dr. Makanjuola, again, he is a colleague too, someone that we met on the field. And I'm so proud of you to taking your take time out even to discuss this and do justice to the topic. It's a privilege to have both of you, and I'm sure my president, he is on transit. I'm not sure he'll be able to speak because I think it's travel, but he's with us even on this webinar. From all of us from the Society for the Study of Pain Nigeria, we want to appreciate Dr. Jokotade Adeleye and Dr. Akintomiwa Makanjuola, both from the College of Medicine of the University of Ibadan, to say thank you, University College Hospital Ibadan, saying thank you to you for taking out your time even to do justice to the topic, that pain in diabetes. Thank you very much, and God bless everyone. If you want to join,
thank you very much, sir. We're very grateful.
Yes.
Dr.
If you want to join
Dr.
the
Dada, I think
please go
we'll
ahead.
be looking forward to the two of them joining the society.
That's okay. That's what I've said. If you want to join the Society for the Study of Pain, and extending invitation to both of you joining us, just take note. I'm going to put my phone number in the chat. Just reach out to me via WhatsApp, and we will discuss. I will send to you the requirements for joining Society for the Study of Pain. Again, I say to
Thank you.
everyone is involved in the management of pain. I am so sure that we can say it again, that if pain is not part of the symptom, most of our patients may not come to the hospital. But today I've learned that even when it is painless, it's also very dangerous, because pain definitely is a protective mechanism. Thank you very much, everyone. My number is posted, and if you can reach out to us.
Thank you, sir.
You're welcome, ma'am.